Oh, I see we have got quite a few folks in now, so I will kick it off. Hello, everyone. Good afternoon and welcome. Thanks for joining us today. On behalf of the Women's Caucus of the American Public Health Association, I want to thank you for joining us for part two of a critical discussion: federal funding cuts, the threat to women's health research programs and services. My name's Maya. I'll be serving as your moderator for the hour. And we're here really because these are urgent and unprecedented times in this country, in the state, and also from a local perspective. So we're witnessing the systemic dismantling of women's health protections, of reproductive rights, and access to life saving care. Since the fall of Roe v. Wade, harmful legislation has kind of swept across the nation, banning or severely restricting abortion, defunding reproductive health programs, targeting LGBTQ plus care, and undermining public health infrastructure. These laws are not just political statements, they are policy choices that put lives at risk. They harm all women, rural communities, and those already pushed to the margins. We're seeing the effects in real time as clinics are closing, maternal mortality is rising, and essential services are defunded. Entire communities can be left without access to care and reproductive services, as well as preventative services. So today you'll hear from a few leaders who are on the front lines of this fight. They're organizers, they're researchers, they're practitioners, and they're advocates. And we're honored to be joined by two incredible panelists that will share insights into what's at stake, what's working, and what we need to protect for the progress we've made and how we can push further. So before we begin, there's a few quick notes. The session is being recorded. We'll be sharing that with all registrants after the call. You're invited to share your thoughts and questions. So anything that comes up as we start to discuss with panelists, there's a Q&A box below. You'll direct your questions there. We'll reserve some time towards the end for group reflection and a brief Q&A, but this is a 1-hour session. So if we can't get to all of them, of course, stay tuned for what's to come next. And then feel free to use the reaction tools to engage with our speakers as you see fit. So that's a lot. With that being said, we'll kick it off by introducing our panelists, starting with Nan Whaley, the president and CEO of Planned Parenthood Southwest Ohio. Let me pull it up here. Nan is an experienced public servant who has spent her career addressing inequities and protecting reproductive rights and health choices for people in Ohio. She moved into her role as president and CEO of Planned Parenthood Southwest Ohio within the last year. And this has been a next step in this important work she's been doing for over 2 decades. In more than 2 decades of her service to the community, Nana served as the City of Dayton City Commissioner and then Mayor, and then Democratic nominee for Ohio Governor. And most recently, before this role, she was also a director of membership for the U.S. Conference of Mayors. Nan has been a constant supporter and advocate for Planned Parenthood in Ohio. And as a candidate for governor, Nan centered her campaign around the issue of protecting reproductive rights and healthcare access. She's a strong leader. She has a million relationships, I can say myself. I've seen it in real time, organizational skills, and have helped drive growth in our community in the state of Ohio and even the country as a whole with initiatives that were targeting gun violence as well as reducing the spread of diseases through needle use. During her tenure with the City of Dayton, Nan worked to advance economic development, improve education and job opportunities, and address issues of racial inequity and poverty, as well as gun violence, like I mentioned, all of which helped to promote a healthy environment for her constituents in Ohio. Our other panelist is Natalie Brogan, a public health professional with over 7 years of experience in research and evaluation of public health programs with the Joint Public Health School of the Old Dominion, Ohio. I'm from Ohio. The Old Dominion University and also Norfolk State University. My apologies. She has a strong background in project management, survey development, data collection, analysis, and report writing, and has held research and managerial positions in domestic and international settings. Mrs. Brogan has experience in academic settings, nonprofit organizations, and government contracting firms. Her experience working in international settings focused on medical education and health workforce development. Ms. Brogan also currently serves as the assistant to the dean for special projects in the Joint School of Public Health. So that is at Old Dominion University and Norfolk State University. She also received her BS in biology from Virginia Commonwealth University and her MPH in maternal and child health at the University of South Florida. She's fluent in German and Spanish, and she spends her free time with her family outdoors, gardening, cooking, reading, swimming, biking, and running. So with that kickoff, we will jump into our directed questions. So we'll start with one for Nan, and then we'll move into the next one for Natalie. Nan, your first question is, As a longtime public servant and now leader of Planned Parenthood, what do you see as the biggest political and operational threats to reproductive health services in this current climate?
Thanks, Maya, and it's great to be on. Thanks for including me in this conversation. I think, we're in pretty unprecedented times for the modern era, particularly around sexual reproductive health. We've seen just in the past 5 years, if you think about this, the fall of Roe with the Dobbs decision that has made abortion access extremely uneven across the country, depending on which state you live in, if you even have access to abortion. So that we've been seeing that before with states limiting and limiting and limiting, and now with that complete protection gone, we have many states that have no access at all. And then we are in Ohio. One of the bright sides in Ohio spots in Ohio is that we do have abortion access. We were able to pass it on the ballot in 2023, but it has changed the way that we've been able to provide abortion because our Cincinnati clinic is the first abortion clinic for 1,301 miles along I-75 from Key West. And so we're seeing the movement of people trying to get care from Indiana, Texas, Kentucky, Florida, Georgia, Tennessee, coming up that I-75 corridor, which has been a real change for us in both Cincinnati and Dayton as the entryway to care for people that have very few options where they're living today. So you have that challenge, and then this July with the reconciliation bill that was passed and signed on July 4th, the loss of Medicaid to all Planned Parenthoods across the country. So what that does is even if you're a state that is protected with a governor or a state legislature that is friendly to women's health and sexual reproductive health, you're seeing cuts for poor people to get access to any sort of preventative work, family planning, for birth control, for cervical screenings and cancer screenings, for STI testing going away. And we anticipate, and National Planned Parenthood participates, of the 600 clinics that we run across the country, 200 will be closed because of that, because a lot of the work that Planned Parenthood does is preventative care for family planning for people that don't necessarily have means that are on Medicaid, and that's going away. And for us, like we've seen that here in Ohio, just this past week, we had to announce the closure of 2 of our family planning clinics and health centers in Springfield and Hamilton. And these are places, again, that don't have a lot of options. When we closed Springfield last week because of the loss of Medicaid, the Springfield Foundation told us that there's only 4 OBGYNs in that entire community. And so the loss of Medicaid for particularly preventative health is going to have a huge impact. And we're just beginning to see it. We're only in 21 days since the bill was signed, 3 weeks, and we're already seeing those impacts. We're also seeing the announcement of a closure of a health clinic in Evansville over these. So the state is not good, Maya, I think is what I would say. And we're clearly going backwards, which is really difficult for something that for decades we've been able to move forwards. And I think that is what's so hard, particularly with the changes around Medicaid for sexual reproductive health. We can talk about other health challenges, and particularly in already healthcare deserts that will get, frankly, even more dry as this moves on. So not a good day today.
Thanks for sharing, Nan. Along a similar vein, Natalie, with your background in research and evaluation, how do you see funding cuts impacting academic public health programs and the pipeline of new maternal and child health professionals?
Yeah, thank you, Maya, and thank you, Nan, and thank you for letting me be here and be on this panel. It's great to be able to just kind of talk about it. First and foremost, I want to say I know all of us are here and we've showed up and we all have that public health passion. And I think what these funding cuts are really affecting us in that trickle down effect, right? Like what Nan was saying, it's this big picture, and then you start seeing these small clinics closing, and it's small over time, but it's actually a huge impact. Within the academic public health field, it affects, of course, the research our faculty are doing. we have such an interdisciplinary discipline, and we're very service focused, right? And so as we are doing these collaborative efforts with our community partners, if our faculty aren't receiving the funding or aren't able to do their research, whether it's frozen by funding cuts or whether they're not able to apply for the grants that were previously there, those affect the research they can do within the communities. So the community health suffers. Also, we see that there's when faculty are applying for grants and receive grants, then they are hopefully supporting graduate students. So those graduate students who may have had an opportunity to have their graduate assistantship or tuition covered or a teaching assistantship, that opportunity, they then have to decide and weigh that financial option. And then just, building up that public health workforce that we want to go out there and work within the public health fields within the community. So again, it's really that trickle down. And my evaluator hat makes me want to say, okay, how do we switch this around and try and find the opportunity for growth? And I know that's very unicorns and rainbows, because it doesn't always feel that way. But how do we work within our communities? How do we find that, non-traditional funding, or be creative in where we go to find the grants for our faculty, to be able to do the research, to have the students, and to work with the community members. And, in reference to the reconciliation bill, as they cut that funding, that affects our community members. And then in, academic public health partnerships, we work with the Department of Health here at ODU, at the Joint School of ODU at NSU, and we have collaborations with the Department of Health. And so when they lose funding or are unable to do a project on frozen funding, and then we're there to be a resource for them, and we don't want to lose that opportunity to be able to help establish a healthy population. In terms of, the maternal and child health future workforce and students, again, I think as we continue to have these discussions and advocate and put ourselves out there, our passion will continue to bring in the students who see that need for maternal and child health. As long as we keep talking about it and using real life examples and advocating, then hopefully, we'll continue to bring in those students. Again, I know I sound very positive, and there's not every day I'm not that way, but I want to be that way. So I continue to speak to that because, hey, we're all here talking about it. So, yeah.
No, I appreciate the perspective. And I think I won't speak for Nan, but working in such a world of reproductive healthcare, it's hard to find that positivity in these times. I mean, we feel like left and right, we're kind of it's like death by a thousand cuts, hit from every angle. So to have folks on sort of like the academia side doing a lot of like the long-term research and kind of like the groundwork for organizing like we do, it's comforting to know that you still can find positivity in that work. Kind of along that vein, a question for both of you is, what strategies give you hope, whether grassroots, legislative, or programmatic, for safeguarding the future of women's health in this country?
Natalie, you go first. You're the more hopeful one here.
So, no, I think, and I'll say I'm trying to put myself out there in terms of getting on more women's health research to listen and see what's going on and see who's doing what and where, because evaluating that perspective of where everything is now, obviously we know funding's cut and there are certain ideas of what women's health should be within our country. And I think trying to properly communicate why it's so important and research every portion has its part. It's like a puzzle. You have to have all the puzzle pieces together, and it's trying to listen and see where we are, and be a voice without, not without bringing attention to us, because it is important, but without being so loud that it's too much. I don't know if that makes any sense.
No, I think that's right. I
Yeah.
mean, I think that's hopeful for sure. I, I think, Maya, for me, I think the hope is like, while we see these like dramatic attacks by really like extreme legislatures is what we're seeing. They just have to happen to have the power right now, which is the key point. The public is actually very, very supportive of the work that we do, and that's frankly, again, we're sitting in Southwest Ohio, and we have 20 counties in Dayton, Cincinnati, 3 counties in Kentucky, and when I was Maya's age, that was not the case, and to feel that support across the community is I think something new for reproductive health, and the support we get from people supporting us financially is so impressive, and we are very grateful for it, and we recognize that. I think that is something that gives me hope, right? Like, we have to realize that we're going to have to organize our way out of this, and power is not taken away easily. And so to see that support and how strongly people feel and are with us in that work by such a large margin, I am just very hopeful about that, because at the end of the day, I believe that is what really matters. And people using their voices to stand up for other people that necessarily can't is something that is very hopeful to me.
Absolutely. Thank you both. Another question for you, Natalie, is you've personally navigated a cancer diagnosis and remission while working in the field. How has that experience shaped your views on access, equity, and the human impact of public health funding decisions?
Yeah, so that big question. So a little bit. So I was diagnosed in 2021 at the age of 36 with ER/PR, so hormone positive, HER2 positive breast cancer. And it taught me, I had to kind of figure out two hats, right? Patient, public health. But also, I will say, in terms of access, equity, a little bit about the history. So my sister and one of her friends were running together Saturday mornings. And so I kind of hopped along, and our friend, now mutual friend, happened to be a breast surgeon. This was before I was diagnosed. And so and she knew, we were running one day, and she pointed out, oh, this couple biking. She's like, that's the oncologist I refer my patients to. And so it turned out that the team that I needed was already formed before I needed even knew. So it turned out that she was my surgeon, and then the other woman was my oncologist. So in terms of access, I was fortunate enough to have them as my providers, but I would also run with them on the weekends, and I biked with my oncologist. And so that gave me the opportunity to kind of ask those public health questions, take off my patient hat, in terms of, why are we seeing increased rates among younger people in their 30s and 40s? Usually it's 40, you get a mammogram. Um, and and so I think in terms of access and equity, it made me think about, the cost really of how much it is. So when I got my first bill, one day in the chemo chair was $70,000. That's what was charged to my insurance. Now, of course, I met my deductible, and that's not how much I paid. That didn't go to my oncologist. But I was able to ask my friend, well, why how is it that high? So it made, and she said, well, you know, some of that money goes towards research and development. Okay. So, calculating it out, I had a total of 20 rounds of chemo and a double mastectomy. So that's over $1 million of care, right? So I started looking at it not yes, from the access point of accessing care, even preventative services, but also when you get your care, is it affordable? But that shouldn't even be a question, right? Like it shouldn't be, should I go get it now? I think I have something. Maybe I should wait. It should be, I have something. It doesn't matter. It'll be covered. And so I started looking a little bit deeper into policies in terms of coverage, Medicaid coverage, Medicare coverage, and then also where that funding pot sits for any research. And I, you know, someone told me, well, there's a congressionally directed medical research program under the Department of Defense for breast cancer. And I'm like, well, why? Why does it fall under the DoD? And I recently met a girl my age who was in the military who is covered under the DoD. And so I did a little bit of more digging, and it turns out that they do these clinical studies. Being in the military, your risk of cancer has increased just because of exposures. And so there are women in the military, that's where they've put the funding. And so it turns out that because I was HER2 positive, I had two drugs, Herceptin, which is a monoclonal antibody for HER2 cells. That was approved for early stage breast cancer, which is what I was in 2006. So another one that I took was Kadcyla, which was also HER2 positive. And for my diagnosis, it was approved in 2019. So it brings to mind, like, this is an example of why this research is so important. And that, like, if we didn't have this, this was just approved in 2019, like, where would that put me today? So, how important that funding is and seeing where it comes and where it falls. And so I did look up to see how much money they have appropriated for the fiscal year 26 under that congressionally directed DoD funding, and it's $150 million, which is fantastic, right? But if my care is 1 million, 150 million would cover 150 women. Now I know it's not that easy of a calculation, right? I'm not that into economics, but just that perspective of, wow, it costs this much. So where's that funding going? And if I'm getting that kind of care, then everybody should have that care. It shouldn't matter enough. It should matter that you get that care. There's no question about it. So I think, it's really taught me in those first 2 weeks of my diagnosis and going through it, I was like, why me? Like, this isn't fair. But now I just kind of changed the way that I frame that question. And I say, well, why me? And I see that speaking to this as an opportunity of saying that everybody, this this shouldn't be a question about whether you go in, or nobody should have to decide, like, I need to push my chemo off for a week because I need food on the table. So that's the biggest lesson.
Yeah, thank you so much for sharing and sharing your story. It's really powerful, and I know, like, something that we talk about a lot too that it made me think of is your, like, anecdotal piece about the people you were running with and how it ended up being your care team, and it kind of brings to mind for me sort of the unintended effects of these funding cuts and also heavily, like, legislating the
Mhm.
kind of way we approach women's health and reproductive health care in general. And it made me think of something that we've been talking about a lot, which is when you, like, highly politicize an act of care, potentially attach it to a law in a very punitive way, and you make it gray. A lot of folks don't want to practice in, for example, states with abortion bans, something that we work in a lot. So could the two of you maybe speak a little bit too to, like, the unintended impact of these funding restrictions and also just kind of the fear mongering around accessing certain portions of reproductive health care?
Sure, I think that's right, Maya, when you have these attacks, and we see it even more so right now, I think, in the work of gender affirming care, which we do provide hormone replacement therapy to folks in Southwest Ohio. And we have people travel for that as well into Ohio for that. But you could see the stories this past week on the attacks around gender affirming care in general, that even some places in California have decided, hospitals in California have decided not to provide for it. So while they're even protected by the state, you see changes and people getting the access becomes limiting because of the politicization of healthcare, frankly. Like, these are choices that are made between patients and their doctors. For Planned Parenthood, we stand firmly into bodily autonomy. That's like our centerpiece of these choices are very personal and they should be made by each individual, no matter what. And you can see the effect that has just on the attacks that we're seeing these past few years. I also would say, like, when we see states that limit abortion access, like the South particularly, we also see the loss of family planning that goes with that. And so the limitation of the full spectrum of reproductive health, from comprehensive sex ed to birth control and decisions around birth control and choices around birth control, to abortion services, they actually all come together quite often. And what we see in states that don't have abortion access, they also have pretty paltry family planning options as well. And so they do all go hand in hand. So when you politicize a piece of it, it affects the whole system. And we see that over and over again. And look, you don't have to take my word for it. The studies bear this out. There are smart scientists that are watching closely the number of people that are using sexual reproductive health. And it is very clear, just in the few short years that Dobbs has come in place, that the places that don't have abortion access also don't have access to birth control.
I think Nan said it wonderfully. I don't have anything to add.
Absolutely. Thank you. Another question for you, Nan, and then I'll jump into one final question for the both of you, and we'll open it up for Q&A, is how can local governments and organizations like Planned Parenthood collaborate to protect access to care and strengthen reproductive justice across state lines? So kind of similar to the question that was asked
Right.
before.
Like, I think, one of the things we really try to do is, like, we have 46 affiliates across the country in Planned Parenthood. And so we work to partner with states that don't have access to make sure we create that opportunity, even though it's difficult and travel and expense is tough on patients. And I think we're just, we're in the third year of this new unfortunate normal that will be a normal for a while. I mean, I think this is the case we're sitting in for the next decade. So I think for us, it's really important for us to build the infrastructure around patient navigation, access to care, connecting with places that don't have access, that we can have a connection there. I heard a story yesterday, something we'll look into. There's affiliates across the country that are heavy places for travel, right? Because of their location. We call them a safe haven state, safe haven affiliates, and we are one of those in Southwest Ohio. And others have started also, as been taking patients to do cervical cancer screenings on all folks that come in. So we're not doing this yet. I know I've heard of other affiliates doing this because, folks that have had to come in, again, if they're traveling for abortion services, they probably aren't having family planning services. They're probably not having their regular checkups. So there's an opportunity for us to provide that care and then send that information back to where they're home, and making that connection so we can get folks into preventative care around sexual reproductive health. So that's some of the work that we're trying to do. The challenge again is, these funding hits for us are so dramatic. Like, we're just trying to keep what is absolutely necessary and needed. And, I see just huge opportunity for us to do that preventative care that ties with abortion services over and over again. And I think that's where Planned Parenthood is special, that they're able to do that and connect that way. And I think we're just scratching the surface now, that we're now in such large geographies for travel around abortion. So I think that is big opportunities for us. I mean, we will continue to fight. So, these laws that try to inhibit people that are in a certain state can't travel for care, we'll continue to fight those. We see them coming down the pike. And we'll continue to be an activist on it. And we need people's voices again to stand up and say this is unacceptable. That's going to be so key in this time, for people to speak up and speak out and to educate their friends and neighbors, right? People don't listen to me and they don't listen to Natalie in these days unless they're Natalie's friend or my neighbor. And so getting yourself educated, having some confidence in it so you can share conversations because people trust people they know. And this has really always been the case. We've just kind of forgotten it. And talking about these issues that you don't normally talk to is going to be so important as we really build the fabric of community across places so we can educate folks in different ways these coming years.
Absolutely. Thank you. One last group question. So, how can we use data and community voice to hold decision makers accountable for real life consequences of funding cuts on women's health?
Go, Natalie.
Yeah, I think Nan's also kind of said it in a very beautiful way, but I think as we continue to use real life examples and speak and learn to communicate outside of our what we're used to and use not use but have people who've had the experience speak to it because they can answer the questions or we have to stand up and say something, write your representatives or sit and listen to other people and try and understand why they are where they are and figure out a way how, it's communication style too. And how do we say that we want the right thing? We want healthy communities. We want people to be healthy, have access to these things, even in when we're doing research and in academia too. It's not what we say, it's how we say it. So I think really learning to communicate across multiple perspectives and listening and understanding, I think that, and speaking up as well, I think that will be really effective.
Yeah, I agree. And Natalie, I think it's really important. You have to have the data, of course, but the data has
Yes,
story. And
yes.
people are moved by stories. And we know that, like we know that in the abortion movement, right? The number of folks that have said to me, I told my dad I had an abortion and it changed his thinking about the issue. We know that your story, if you are brave enough to tell it, changes hearts and minds. And so if it's important enough to you, if the issue is important enough to you, you have to give a bit of yourself to the people you care about to tell your full story. And that changes their mind. And so we can't expect people to change their mind if we haven't given them another perspective. I also just encourage, I tell, everyone has a Planned Parenthood story. Everyone does. And so we want people to tell their Planned Parenthood story to their friends, to their family members. It can be empowering. It usually is a very empowering story. We change lives every single day for people in our clinics. And we like it when they tell those stories to their friends, neighbors, and family members. And so taking, that data, 1 in 4 women have had an abortion and having those 1 in 4 women tell their stories. Imagine the power of that in our country and in our communities if we do that.
Absolutely. Thank you both. At this time, we will open up the Q&A to some folks in the audience, so feel free to drop some questions into that little Q&A box you see down below. I can kick it off with one that I have, which is, as someone from Appalachia in a very rural area, obviously when we hear about things like funding cuts, the first thing that comes to mind for me is we really can't afford to lose anything more. We've got 30-mile radius, one hospital at a time, which is obviously not ideal, especially in the case of emergency situations when a lot of folks are Medicaid recipients and they are very strapped for in-network provider access in the first place. So could you both speak to kind of what communities we need to keep an eye on in the face of these funding attacks and crises as we kind of work through the fallout of these decisions from the federal government?
Yeah, Natalie, who do you think is first in the line here?
You go ahead.
No, so I just think it is honestly, I think rural communities are going to be the toughest hit. We're seeing that they already exist in places that they don't have access to OBGYNs. They don't have access to places to get pregnant, any sort of pregnancy services at all. If they decide to take a child to term, it's very difficult to get there. And we're seeing more and more closures of that even before the Medicaid cuts. And rural hospitals survive off of Medicaid. I mean, that is just a fact. And I've told folks like these closures from Planned Parenthood are the tip of the spear on that, but the rural areas are going to be hit very hard. And then I would say, at least in Ohio, the children's hospitals are going to have a very hard time. Again, a lot of children are on Medicaid, and so these cuts, while some will still be protected, many won't, and that is going to affect as well. And our children's hospitals, particularly in Cincinnati, does a lot of research-based work, and so we're going to see that attacked because the Medicaid funding for these hospitals is just going to be very, very difficult. The challenge here for me as someone who wants people to understand why these things happen, I think that's really important. That these decisions don't happen in a vacuum, that it might take a few years. For people will try to hold on as long as they can, of course, because they want to provide great care. And it is this moment that is going to have the consequences for the next 5 years. And we'll see it as a drip, drip, drip across the country.
Yeah, I couldn't agree more. And I think also those, other free clinics or FQHCs where they may be receiving Medicaid funding, will also have some trouble. And also what we've seen too is areas of lower socioeconomic status, even in cities, finding out that there are cities close to us that don't even have OBGYNs within their city. So, and within funding cuts, yeah, I couldn't agree more with Nan. Yeah, just adding those areas.
Yeah, the FQHCs, I'm glad you mentioned those, Natalie. They're going to be hit hard, and particularly that'll be the hit, particularly in urban areas that we'll see.
Yeah.
Thanks, y'all. A question for you, Nan, is from Teresa McKenzie is, we know that Planned Parenthood provides women health care, but are men able to get services as well? If yes, what kind of services?
Yes, particularly we provide a lot of transgender services for hormone replacement therapy. So people that identify both as men and women come in to our clinic. And then we also provide vasectomies at ours. So as well at Planned Parenthood Southwest Ohio. So we do have vasectomy services as well, and STI testing as well for both sexes. So yeah, so quite a bit of services that are for both the entire community. Did I miss any, Maya? Maya usually checks to make sure. Did I get them all?
You got them. That was good.
All right, that's good.
I'll add that anyone that wants an STI test can come to us as well. So
yeah, I did. I said that. I said
you
that.
did.
Girl. Yeah, I
You
got
did.
it.
You did. Great job. Another one we're seeing, and I think I'd love to hear like a data perspective on this too, if possible, Natalie, but it's generally kind of the concept of cutting back Title X, cutting back funding that goes towards abortion providers, in an attempt to kind of like re-centralize this idea of like the American nuclear family. Can we talk about just like kind of that messaging, why it's harmful, and kind of what our take is on why these funds are being divested?
I don't know that I would necessarily have an answer for that right now. I think I'd have to think about that one. That's a big one.
It is a big one. Sounds like that's one though we need to think on. But thank you for submitting it, commenter. Well, we've got a little bit of time, so if anyone else has any questions coming to mind, feel free to pop them in here. Something else I think is important to like spotlight in this discussion is that these, like, for example, what you mentioned, Natalie, about other like more accessible non-insurance requiring providers, as well as like Planned Parenthood, for example, while we do offer particular services, some folks are coming to us out of last resort. So like if anything's wrong and they're in need of a referral, it's also like an avenue for folks to access that. So whenever federal funding cuts kind of attack those institutions, restrict funds, it makes it a lot harder for folks to get their basic needs met, even. Um, so I would just add that as well if there's anything you all want to say about that piece. So we're talking about women's health, and also we're talking about just generally like, what do you do if you have a fever and you're uninsured?
Right. You just go without, right? And so then if it gets worse and worse, this will affect like the emergency rooms. One of the great things about Medicaid expansion is the preventative care that people were able to receive at federally qualified healthcare centers, at Planned Parenthood, at general docs really helped. And you did see the emergency room numbers, they did go down. I was an elected official during the fight for Medicaid expansion. And that's been a real change. Like that isn't something that was discussed during the expansion. And now we're going to go back to that as what is going to happen, because people will not they'll do without. And that's what folks do when they don't have access or don't have the ability to pay. And that will cost the system a lot more, by the way. Like that was the whole point,
Yes.
right? Like if you like this is a collective system, as much as people like to forget about it. And so, keeping healthcare costs down helps my insurance provider if I'm on commercial insurance. And so we all are still, even though we do have different levels of services, which we could have a whole conversation about how that's wrong. But at the end of the day, like those systems are intertwined. And so that will make insurance premiums go up with the loss of Medicaid expansion in different states.
Yeah. And so in Virginia, we have the trigger law. So that will also add to it. And then you think of all of the federal workers who have been laid off or those who have lost their jobs, and then they lose their insurance. And so where do they go for their care? And then those free clinics or the FQHCs where their funding has been cut, then they have limited. So then, again, it's those ERs that get flooded and, people wait a little bit longer to go have something checked. And then you have, higher rates of more advanced diseases. So, yeah.
Absolutely. It's a tough landscape we're navigating, but just couldn't be more thankful to be in the work and working with folks like y'all who are so dedicated to it. One more question I'm seeing coming through is, if someone was lacking insurance, are there systems that can assist them with medication as well that you all are aware of that maybe you'd want to shout out? It's a tough one because it's touch and go.
Yeah, I'd say that it varies state by state. So I'm not familiar with Virginia's laws and rules. Like I frankly, until Natalie said that, I didn't realize that Virginia also had the trigger on 90% like Ohio does. And um, so it varies. I will say that most of your local Planned Parenthoods do scales for need on ability to pay. So there are places that will look to that. And I would also say, like, for just general, if you talk to an FQHC, they would know those connections. Like I know in my region, there's Reach Out that does that work for pharmaceuticals and prescriptions, but it's usually it's in at least in Ohio, it's fairly regional where those prescription opportunities are.
Thank you. Last question is, while this funding cut has kind of created these unprecedented challenges, like what can we still do to sustain this work? What can we do to ensure the resources we do have and the infrastructure that still exists is protected and preserved?
Um, I'll kind of try to go first. I think kind of a lot of what we've talked about, I will speak to, I know our faculty are still applying for grants. They're still out there doing what they can. We are still out there going to recruiting events. We are using examples of real time in our courses. And I think also trying to, again, at least in academic public health, going back to how do we look for those non-traditional funding opportunities? Where do we find that collaboration, that interdisciplinary work to continue to be able to do the research that leads to policy change? again, everybody has their piece. So where can we keep moving, even though we feel a bit paralyzed, but also speak out and speak to, and like Nan said, use the data and use the stories and have those people, if they're comfortable, speak up.
Yeah, I just echo Natalie. You got to get comfortable speaking out. That's really important in this moment, in this time. And then, you could donate to your local Planned
Yeah.
Parenthood. That'll make a difference. We have been funded for over 100 years from a group of people that believed that people needed sexual reproductive health access. And so that's why, like, while this is painful, the loss of Medicaid, where we started, is very far from where we are today. And so we're continuing to, we'll still be here, and it will look different, but we know that our role is very important in that. And so supporting your local Planned Parenthood, I would really encourage, even if it's a little bit on a monthly donation, it makes a huge difference to provide that care. And then again, I can't say enough that, we've got to talk about these issues more, and we've got to get into the light about them. It does change. You do matter, and your voice matters. And particularly if you're in the healthcare arena, using your voice matters even more, and sharing that, because you're an expert to your family and friends. So just keep that in mind as you're talking about these important issues.
Well, thank you both so much for your time. Thank you, everyone, for hopping on and asking your questions and being engaged. With the time we have left, I'd love to throw it over to y'all for just a little 1 minute closing of your thoughts and kind of your work and what we can look forward to in the future.
Yeah, I'll go. Thank you. Thank you for just this space and this time. And, I think I'm going to kind of repeat and echo a lot of what Nan and I have both said, but, just it's uncomfortable to speak up sometimes, but you never know who needs to hear your story, and you never know who will be inspired by you. And it might not be what you think it is, or what you think you say will change somebody or have somebody speak up. And, again, here at the Joint School Public Health, we're going to continue doing our research. We're going to continue applying for grants. We're going to continue to keep moving, because we all still have that passion. And we will continue to find ways to support our community and opportunities to make sure that we have a healthy public.
Natalie, thanks for being on with me today, and thanks for the Women's Caucus for this opportunity just to talk about what's at stake in our world of reproductive health care. Every day we know that we're witnessing the consequences of our politicians working overtime to strip away reproductive rights. As we've talked today, from defunding Medicaid to passing laws that make it harder for people to access care. I just want to be really clear that we're not going anywhere. Our affiliate's been here for 96 years. Planned Parenthood's been around for over 100 years, and we're going to continue to fight and fight for that care. But frankly, I'm just begging you to get in the fight with us and to, support these efforts, to share your story, to speak out. We know that this is about the future of young people. And the kind of future that we want them to live in, that will be, it can be better than what we're living in today. And, your work, your activism, your actions will make a difference in that work. So I appreciate everyone staying on to listen to us, and just really thanks for the time, and thanks for the support of women's health and reproductive access.
Thanks so much, both of you. Natalie, quick question that just kind of popped up in the questions and also was kind of on my mind. Anything research-wise you all are looking at right now that the general public should maybe be taking a closer look at, as far as women's health and the impacts of data-driven results?
Yeah, I would say right now, so we're still a fairly new school. We were just formed as the joint school in the fall, in September of 2024. So we're still, while we are a merger of three programs, we are still building up. So I would say more to come on that. So just keep your eyes on us. And also, thank you. Thank you, Nan. It's also been wonderful being on this panel with you. So thank you.
Natalie.
Yeah. Thanks, y'all. And thank you, everyone, for being here. As we kind of wrap up, I just want to encourage you all to really heed the words of Natalie and Nan. Make sure you're sharing your voice. We truly do not understand the power that we hold when we're collective in our action and in our voice. So don't undersell the importance of letting folks around you know that this is something you care about and this is something we should have more of an eye on. As a reminder, also, this is recorded, so if your colleague or someone wanted to hop on, they didn't get a chance to hear, it will be sent out to registrants, the entire video, so be on the lookout for a follow-up email including that. If you're interested in getting involved with the Women's Caucus, follow them on Facebook and LinkedIn, and stay tuned for future webinar topics.
Thanks, Maya. Good job.
Thank you, Maya.
Thanks so much,
Bye.
everyone.
Thanks.
Have a great day.